are. So anytime. All right, yeah, go ahead.
Okay. So I'm Professor David Byrne, and today's Sunday, the 5th of June, 2011. I'm interviewing Professor Andrew Lees, who's been involved with the Movement Disorder Society since its formation. We're here at the 15th International Congress in Toronto, Canada. So Andrew, I think pretty well most people in the movement disorder field know you from Liverpool. Could you just maybe give us a little bit of a feel of your early years and your educational background?
My family are from the northwest of England and have lived there for at least 200 years. Many of them were involved in the cotton industry and in the mines. So, in fact, both my parents were from the Manchester area, and that's where the family come from. So, when I was born closer to Liverpool, this was a bit of a major move as far as, although it was only 30 miles down the road. So my father, for example, is who was a teacher at the local grammar school in St Helens, which is the place I was born, a few miles outside Liverpool. Yes. Remained a Manchester United supporter, so I'm the only Liverpool Football Club supporter in the family. And my brother, who was born a few years younger than me, is also a Manchester United supporter, but I maintain my allegiances to Liverpool and the coast.
Very good. So when did you actually get to your first Liverpool game? How old were you?
I was about 9.
Right.
My father took me on the Kop.
Right.
And,
that's a pretty impressive. I guess that was some experience.
That was the days when the Kop had 20,000 people all standing and shouting. Dockers would come straight from work.
Amazing. Amazing.
And of course it was in the early 60s when the club was just beginning to develop and go through its great days.
So get it. So I mean, your early education, was that all in St Helens in Liverpool?
Yeah, well, at the age of 10, we moved to Leeds, so that I went to a grammar school in Leeds. This was like being in foreign territory, because we're on the other side of the Pennines, and as you know very well, there's the land of the White Rose, and there's a great enmity between Yorkshire and Lancashire, and in fact it took me quite a while to settle down.
Did you have quite a hard time at school because
you
come across
different accent? Nobody knew what pumps were or galoshes, so the language was a little bit different. So it took me a little while to find my feet at school.
Yeah. So when you left school, whereabouts did you go to from Leeds?
So I mean, at school I passed the 11+ exam, which was an exam, as you know, in England which no longer exists, which divides children on their academic abilities at the age of 11. So I went to the local grammar school in Leeds, and actually I took my 11+ exam a year early, so I was in a year older than I should have been, which I also found very difficult to actually adapt to at the time. So it took me a couple of years to kind of find my feet, and during my teenage years I got very interested in natural history, and every summer holiday I had a different passion. So one summer holiday I'd be studying birds, the next summer holiday I'd be studying butterflies. I joined the Leeds Naturalist Association. We used to go on rambles to the Yorkshire Dales, but the thing that I was most interested in was entomology and the study of ants, and I did quite a lot of work on little projects on ants during summer holidays. And really, as I got to the time where I wanted to had to decide what I had to do in my career, I wanted to be an entomologist, but very wisely my parents said there weren't too many job opportunities in studying ants and beetles at that time. So they kind of wisely directed me in the direction of medicine, knowing I was very good at biology and not terribly good at maths. So I was in like many people who go into medicine, not a hard scientist. I had a great interest in English literature and geography and other things, as well as the sciences.
So it seems almost like as if your parents thought that that would be a good fit for you, and you clearly didn't rebel against their suggestion.
No, I partly rebelled against it, but I did go into medicine slightly unintentionally, or
Right.
by default, perhaps, would be the best way to say. And as you know, in those days, you had to go for interview to different medical schools, and a lot of the applications depended on how you got on at the interview rather than with your academic results. So one of the first places I got an interview was at the London Hospital, as it was then called, in Whitechapel in the East End. And I was successful. I got in, and that was the beginning of my medical training at the London Hospital, yeah.
Okay. So, I mean, thinking back in those days, I mean, neurology would have been a fairly young specialty. So what was it, I guess, firstly, that drew you into neurology, and then perhaps more recently drew you into the sort of Parkinson's area?
Well, the neurological tradition of the London Hospital was strong.
Sure.
Hewlings-Jackson was there, Henry Head was there, and so there was a feeling of neurology being very strong at the London. And when I arrived, Lord Brain had just retired from the staff, but he'd left a legacy of neurology, and the teaching was inspirational, really, at an undergraduate level. We had Ronald Henson, who's best remembered for his work on paraneoplastic syndromes, and also his interesting book, Music and the Brain. Chris Earle, who later moved to the Middlesex Hospital, was there. And the neurosurgeons were Sid Watkins, who is the neurosurgeon for the Formula One racing for a long time. So it was a very strong
yes, that's an amazing
team of neurologists. And we, as undergraduates, we had to present cases in the old-fashioned way and the anatomo-clinical methods of teaching. So we had to present a case to Dr. Henson or Dr. Earle with the audience, and the patient would come in. So I was taught very early the standard way of teaching and training of neurology. And but I think also a thing that was very inspirational for me at the London were the teaching autopsies. And every lunchtime we used to troop down to the mortuary to see the post-mortem examinations on the patients under the firm where I was working. And this was not only educational with respect to learning one's medicine, but it was also humbling that how often we got it wrong. And the neuropathologists were also very strong at the London there. Dorothy Russell was there, and Henry Urick. So it was really, the neuropath was really something that I think had a great influence on my subsequent career and my later interest in brain banking and becoming a bit of a dilettante in neuropathology.
Yes,
so.
yes. I mean, so really, I mean, was it more the fact that you were inspired by those people like Chris Earle, who I can just vaguely remember myself actually, as sort of really good teachers that sort of drew you into neurology as a specialty? Is that really how you think it was? Or was there something more intrinsic about the actual specialty itself that you liked as well? Or was it more the teaching that inspired you and drew you into it?
I think it's a bit of both, but I think the intellectual aspects of neurology intrigued me, and the diagnostic methods seemed to be more complex and a little bit more sophisticated than some other areas of general medicine. So I think that was probably one of the things. I was also interested in classification and pattern recognition, which I suppose may have come in part from my earlier interest in natural history, which perhaps attracted me a little bit to neurology, because even in those days there were many diseases that were not really properly classified, and the nosology was still very fluent. You know, it was changing really. So that may have been another factor.
So they obviously piqued your interest, and that was at the at the London. So just sort of take us on from there. What became of you from the London?
Well, one of my first house jobs, I moved west to St Stephen's Hospital, which is now Chelsea and Westminster Hospital. And I was fortunate, I worked for a general physician called Dudley Hart, who was a rheumatologist, but he saw, in those days they saw neurological patients too. And one of the very first patients on the ward, this was in 1969 when I was doing my house job, was a patient with really very severe disabling Parkinson's disease who was being offered this exciting new treatment called L-DOPA. It had just become available. The trials had just finished. And I had the good fortune of being probably one of the very first UK physicians to actually prescribe and use L-DOPA. And really the effects were spectacular and miraculous. Within a couple of weeks of treatment, the patient was able to get out of a wheelchair that she'd been in for several years and regain a independent existence. So it was really, I thought, if neurology is like this must be the area for me to go in. And there was of course it was the 60s, and there was an air of excitement generally that we could all change the world anyway. But this really seemed to me as if it was going to be the beginning of a new era where neurodegenerative disease was going to be cracked. Yes. So that really excited me and interested me, and it reminded me also of, I can remember at that time remembering watching as a teenager when I was at school, one of the programs, I don't know whether you ever saw them, called Your Life in Their Hands. There were programs of miraculous new developments in medicine, and one of the very early ones was by Sir Charles Fletcher, who chaired the meeting, showed a patient with Parkinson's disease who'd had their tremor cured by a surgical approach, which of course was a thalamotomy in the 60s, and that also I thought had a big impression on me at the time. So I think those two episodes really were things which moved me towards Parkinson's disease.
That's very
later on.
So this was during your house job.
That was during my first intern house job.
Right. Yeah. So just kind of move us on from
going on
there.
From there. Well, I did my house jobs and and then I did my senior house jobs at the Royal Free Hospital, which is in a teaching hospital in North London. And then I decided to take. I went through a kind of phase where I wasn't sure actually whether I wanted to really carry on doing medicine. So I decided to go to Paris for a year, and I got a job at the American Hospital in Paris, which is a private hospital where the rich and famous are treated. And while I was there, I met Dr. Gautier, who was one of Francois Lermit's assistants at the Salpêtrière Hospital. And he started to, he could see I was interested in neurology still, and he encouraged me to go with him to the Salpêtrière Hospital. And I started to go there and attend the meetings and the lectures there. And that kind of brought me back into medicine, and it really made me think I did really want to do medicine after all, and particularly I wanted to do neurology. So that year, which was a kind of beginning of a bum circuit year, if you like, actually helped to bring me back and cleared my mind about what I wanted to do in the future. Right. So when I got back, I immediately started to. I was lucky because in those days, if you stepped out, it was hard to step back. Very, very difficult to step back in. But anyway, I got picked up by UCH, and I got a job as the resident medical officer at UCH, and I started to attend the clinical demonstrations at Queen Square. This was the time when I was doing my membership, second part of my membership of the Royal College of Physicians exam. So I needed to. So I started to go to the clinical demonstrations at Queen Square, where people like MacDonald Critchley was still, although he'd retired, was still demonstrating. McArdle, Roger Gilliatt, Chris Earle were giving, and these demonstrations I also found very. I remember going there and saying I'd love to work here. Yes. When I was sitting listening to them doing the demonstration. So I think all these things were influences. So I then did my general medical training at UCH, passed the membership exams, and started to work for Gerald Stern as neurology registrar at University College Hospital. And Gerald's senior partner at UCH, there were only 2 neurologists at that time, was William Goody, and who was also on the staff at the National Hospital and who had replaced Sir Francis Walsh. And I remember the first ward round when William said to me, "Don't bother reading Brain's textbook of neurology or any other of the textbooks of neurology, Victor and Adams, forget it. Just read Proust, read the whole of À la recherche du temps perdu, and concentrate on studying the methods of Sherlock Holmes." And I wondered what planet I was on, quite frankly. But 20 years later, I realized that there was a lot of sense in what he taught me.
Interesting, very interesting.
So that kind of gets us to, and of course I came under the influence of Gerald, and Gerald is really my academic father. He supported me, helped me a great deal to negotiate the labyrinths of British neurology and how to get on in neurology.
Which were fairly considerable in those days.
Which were really quite difficult in those days.
Did you come across any prejudices a bit strong, or biases, because, if you like, you were a lad from the north? I mean, did you feel that, any sense of that?
Yeah, I did, yeah. But I think some of it was in me rather than that the prejudice was really there. So I had a bit of an inferiority complex for a while, I think, and I found it really quite difficult. But I have to say that I think most of my teachers and the physicians at Queen Square, which was really a very elitist ivory tower at that time, were very supportive to me, and I can't really say that anybody was unkind or unfair, but there were cliques and there were favourites, as there always are in medicine, and I found I got most of my support from people like Chris Earle, who knew me from the London, John Marshall, who was a Mancunian who was working at Queen Square, had come down from Manchester, and
company there.
Yeah. So I think they helped me a lot.
Yes.
I remember once going to see Roger Gilliatt, who was the chairman at Queen Square, to discuss my career prospects, and the first thing he said to me, I'd been working for him at the Middlesex Hospital as his registrar, so I knew him reasonably well, and he'd always been nice to me, although I was very frightened of him. He could destroy you, really, and I used to bring shoe polish in to clean my shoes at lunchtime before the ward round. I was so scared to make sure. Anyway, I went to see him, and the first question he asked me is, "Do you have independent means?" And I said, "No, I don't, and I'm recently married. I've got 2 small children." So he said, "Have you seriously thought about neurology? Do you think neurology is for you?" And I was affronted, quite frankly. Yes. I thought it was insulting that he'd asked me that. But again, later on, as your career goes on, you begin to realize that these questions are often very important, and we all pay a huge penalty with respect to our families from the dedication we put into training to be neurologists. And then I asked him, I said, "I'm interested in Parkinson's disease." And he said, "Why would you be interested in that? We don't know what causes it. There's no diagnostic tests that you can do to prove it. So there's always an element of doubt about the illness. And if I was you, I would recommend that you take up epilepsy research and work in the telemetry unit." So fortunately, I went back and spoke to Gerald Stern and also to John Marshall, and neither of them said. They said, "Just don't ignore it and get on with. You must follow the path that you want to do and get on and do what you do."
So they were very supportive.
Yeah. So then I did my research, which was on the clinical pharmacology of the Onoff Syndrome. I also did a bit of lab work with Gerald Lees at the Institute of Neurochemistry at Queen Square, but the main research was looking at the phenomenology of the Onoff Syndrome, which had been first really demonstrated in the mid-70s to try and detect different patterns and sequences and try and understand the pathogenesis of what caused it to happen. And Gerald very kindly allowed me to go on a US tour, so I visited Stan Farn, who was extremely kind to me. I visited Gil Glazer, who was the chairman at Yale at that time, and I also visited Mel Yar and Roger Devoisin at Mount Sinai. So it was a very nice trip, and they, I think, further encouraged me and made me realize that if I wanted to make a bit of a name for myself in neurology, I needed to get outside the UK and travel around a bit and put myself on the international map, not just concentrate on working at Queen Square.
So you did your research and you were a registrar at the time?
Yes.
Because people will sort of, realise, I guess, that in those days in the UK system, you pretty well needed to have a higher degree, didn't you, to get on in neurology?
Yes.
So then did you have it in your mind at that point that you would always keep an interest in research? Or because a lot of us always associate you with being a top-notch clinician. Mm-hmm. You thought the two could go together and you would try and keep it going. Yeah,
I've always, and I still have a very uneasy relationship with the university. I see my lineage, if you like, coming from the great Queen Square physicians, and also from Charcot, really, where the bedside was my laboratory.
Yeah.
And I still feel that's where I come from.
That's where the questions start.
Yeah, and so I've always found it quite difficult to integrate myself very easily in university life. But and as you know very well, in the United Kingdom, the division has become greater now. So it's harder to be, I suppose one could call it, a bit of a dilettante in research. You've got to be a serious academic to really do what we need to do. So there's been some tensions there, really, with my career. But I think what's saved me has always been my interest in neuropathology, which, of course, was underpinned the discipline of clinical neurology. All the early neurologists were neuropathologists, and I think most neurologists still acknowledge that neuropathology has a very major part to play, at least in understanding neurodegenerative disease. So I think that kind of has helped me to keep my academic work going. And I have to thank, really, David Marsden for many things, but I never worked for David, but we were very close colleagues. Yes. And
was he at King's when you...
At this time, David was down at King's, and he was developing, really, I suppose one could say, the first school of movement disorders in the United Kingdom. I mean, the UK, as you know, David's not been a place where schools have been very strong. In fact, the history of Queen Square developed through individuals rather than a school of neurology. But David unquestionably had a brilliant school of disciples and apostles at King's. And I think when you look back at David's career, his major work was done at King's before he got the chair at Queen Square 17 years later. So
I was just going to ask, actually, Andrew, just give us a little bit of a timeline here, because you're talking now, what sort of time would this be?
Yeah, so we're now about 1979-80, where I've just finished my degree, my higher degree, and 2 years later, early at the age of 33, I was appointed to the consultant staff at the National Hospital, Queen Square, and at University College Hospital. It was a joint appointment, and I replaced one of my teachers, William Goodyear. I mean, I was fortunate, of course, to be in the right place at the right time, as we are, but I was appointed very early.
You were,
Yeah,
I mean, weren't you
yeah.
back in those days?
Yeah.
I don't know, the average age would have been a good 4 or 5 years
Yes,
older than that,
yes,
I guess, for a consultant post. You wouldn't have spent long as a senior registrar.
I
guess.
only spent 2 years as a senior
Right.
registrar. Yeah,
Right, that's very
yeah.
interesting. And so you were on the staff at Queen Square. David Marsden was still down at King's.
David was, of course, David's about 10 years older than me, and David had, by that time, had established his school of movement disorders. So it was after I became a consultant that I had my closest links and relationships with him. And one of the first things I went down to see him about was the idea of trying to raise money to set up a dedicated Parkinson's disease brain bank. And he was, as always, very supportive and very enthusiastic, actually, because most people remember David for his work in motor physiology, and David always used to talk about motor physiology as being his true love, but actually he started off as an anatomist. Right. And he wrote some brilliant papers on the distribution of melanin in higher animals. Right. So when he was at St. Thomas's, so he was always interested in neuroanatomy and neuropathology. So we went to the Parkinson's Disease Society of the United Kingdom, which was one of the only charity for Parkinson's disease at that time who had money, and they fortunately funded the brain bank, which initially was on split sites. So Peter Jenner, who was one of David's right-hand men in the neurochemistry department, did the chemical analyses down at King's, and we did the histopathology up at Queen Square under my kind of hands-on direction, working with the neuropathologists.
Right. So that was the early 80s.
We're now in the mid-80s to late 80s.
Right.
Yeah.
Right,
Yeah.
when the brain bank was getting established.
Yeah.
So where did the Movement Disorder Society come into in your life? And just again, because you were involved, as I said at the outset there, right from the start of the society,
Which is also mid-80s.
Mid-80s.
Yeah.
So
Yeah.
what were your recollections of that and the genesis of the society?
Well, David Marsden, Stan Farn, who as I mentioned, I'd already met and knew from my trip during my research period to New York, were both at the World Federation of Neurology meeting in Hamburg, and they both buttonholed me in the corridor, and they said, if you want a future in movement disorder, you better turn up at this clandestine meeting in Dr. Farn's hotel room this evening at 9 o'clock. So I arrived not quite knowing what was going to happen. And I found Joe Jankovic was there, Eduardo Tolosa was there, Stan and David were there, and I don't know, there's some rumours that some other people were there, but those were the people I remember being there. And that's where the society was founded, really. I think Stan had already had some ideas about it, but we all agreed that we'd work together to try and set up this new learned society which would focus on Parkinson's disease and related disorders. And that was the beginning of it.
Inkling at the time that it would become the way that it has become.
No, and I'm sure if David was around now, he'd be very proud of what's really happened. Yes. And he always saw it as one of his major achievements because he was very keen on education.
Yes. He was a brilliant teacher, wasn't he?
And of course an inspirational teacher.
Indeed, absolutely. Yeah. I've never known anybody be able to put across such a complex concept so clearly.
Yeah,
he had
exactly.
a very good way of doing that. So in terms of your achievements, Andrew, everybody I'm sure watching and listening to this will know many of them, but what do you take the greatest pride from if you sort of look back over the last few years?
I think it's perhaps not the most highest impact piece of work I've done, but I take the greatest pride in the introduction of apomorphine into clinical practice because it's something that I've done directly to help patients.
Yes, that's probably one of the biggest translational things. What was it, just again, so if I can pick you up on that, because everybody just accepts it now that you know, obviously you were right in there with apomorphine at the start, but what actually led you to first try that particular drug? Is there a story there?
Well, as I've mentioned, my research was on the Onoff syndrome, and at that time there was a certain view that the off periods were refractory to dopaminergic stimulation, that there was some kind of hyperpolarization block and you couldn't get around it. So one of the studies that we did, when I say we, was Richard Hardy and Gerald Stern at UCH, was to inject apomorphine subcutaneously during off periods. Apomorphine, as you know, David, is the prototype dopamine agonist, and we were able to switch people on very reliably in their off periods by a subcutaneous injection of apomorphine. And we also tested at that time lisuride, which also worked reasonably well, but didn't seem to be, to us, quite as effective or reliable as apomorphine. Now, this was the time also where pump technology was coming into medicine, particularly in diabetes. So the diabetic specialists were starting to use pump technology for very brittle diabetics. So the idea of delivering a drug through a pump was kind of pinched a little bit from diabetes. And fortunately, domperidone, the peripheral dopamine receptor antagonist, also became available at that time. So it meant that the nausea and vomiting and postural hypotension, which had so limited the use of apomorphine earlier by people like Schwab and Kotzias, we could get around that. So that was kind of the background. And Pepio Besso was using lisuride in pump technology, so we decided to start to use apomorphine. And of course, there were not the regulatory roadblocks and ethical difficulties in the late 80s, and we were able to get on with all that very, very quickly. And in fact, we were able to get it licensed on the basis of one open label Lancet paper. Gerald and I went to the Department of Health Drug Regulatory Authorities in London, showed a video. The pharmacologists on the panel were sufficiently impressed, and they gave us a license. So it's amazing how, when you look at that, that's only 20 years ago.
That is amazing how things have moved on, isn't it, in terms of putting blocks in the way now for doing these trials and the like.
It's really, and I think if something doesn't change, I mean, I think one could say, well, why, with all this massive explosion of advance in our knowledge of what is Parkinson's disease and what causes it, why haven't we made better advances? Yes. And one sometimes wonders whether the regulatory roadblocks are hindering us and delaying us too much now.
No, well, I think there's many people would agree with you there, definitely. So, I mean, obviously you've done a huge amount of work with the clinical pathological studies. Many studies have been hugely cited. Again, if you just had to pick maybe one or two of those that go back many years, which ones do you think you take, again, the greatest satisfaction from or pride from?
I think, well, I think there are two lots. There's the early work that we did with, mainly with Andrew Hughes and Bill Gibb and Julian Fernley. I think that work was, and of course has been highly quoted. The work with Andrew Hughes was really trying to refine our idea of what Parkinson's disease is from the clinical perspective, using the gold standard of Lewy bodies and nigral cell loss. And amazingly, when we started to do that work in the 80s, very few people had done that with carefully clinically recorded cases and then collecting the brains and looking at them. And I do think that work has helped clinicians to be more accurate in their everyday diagnosis of Parkinson's syndromes and distinguish them from atypical Parkinson's syndromes such as MSA and PSP. With Bill, Bill Gibb did a lot of important work on looking at the melanin distribution and the degree of cell loss in different micro architectural areas of the nigra. And with Julian, of course, we looked at the correlations between nigral cell loss and duration of disease, and argued that perhaps the cells in the nigra start to die 5 or 6 years before the first symptoms appear.
Yes, it's interesting. A couple of the examples you've picked have all had clear translational benefits into patients and into clinical sphere, which I think is really impressive, actually. I mean, this is a really hard question, but now if you're kind of looking forward in terms of, say, clinical path work, which is where people associate you, do you think that's going to run its course, or are there always going to be places for these studies? And if so, how do you think it's going to move the field on in the future, the clin path work?
Well, I think it's still going strong now, and the other thread I was going to tell you about, and you're familiar with it, the recent work we've done with Peter Kempster looking at the other end of Parkinson's disease, and what it is that drives that almost pre-programmed late terminal stage of Parkinson's disease. And the evidence from the work that we've done, it seems to be that it doesn't matter how long the duration of disease has been, that clicks in at a particular time in an individual patient. Obviously, it may click in a little earlier if you develop Parkinson's disease at 30 than if you developed it at 60, but it clicks in.
It's very age-locked.
It's age-locked,
yes.
And it seems, and the evidence is increasing more and more, that Alzheimer disease pathology is quite important in driving that late stage, as well as obviously the spread of cortical Lewy bodies up into the neocortex.
So do you think it's something that's sort of age-linked, with the amyloid acting almost as a kind of a fan or a paraffin to augment the pathological process?
Yeah, something like that. That's how I see it at the moment. So, and so I think there is still, I mean, it's of course a very old-fashioned methodology, but because of the development of new stains, the development of the welding in of genetics with this work, I can see it going on for really quite a long time. I mean, we've found new diseases in the last few years: neurofilament inclusion body disease, the progranulin story. So I think there's still a fair bit of mileage in brain banking and neuropathology.
Good to hear. I mean, in terms of I guess it's a slightly personal question of about the dementia side of things, but I mean, I've often thought that it was because people succumbed to the motor problems at an earlier stage when the treatments were less good, that dementia's assumed such preeminence recently. I mean, is that fair, do you think? Is it reasonable sort of model to have in your mind? Because now young people watching this, maybe coming into movement disorders, they're very much sort of brought up on non-motor and dementia as an integral part. But I think, correct me if I'm wrong, but 30 years ago, or maybe less actually, it was not really much talked about.
I was taught that dementia doesn't occur in Parkinson's disease by all my teachers. And my teachers were good observers, very good clinical observers, and I do not, although I mean, some people have made the argument that, well, they didn't see the late stages of the disease because the patients ended up in nursing homes. They did, because a lot of them did domiciliary visits, a lot of them went out to see people in their homes at that time. So I think it's very much what you're suggesting, that we're probably seeing a new phase of the illness, which may partly represent the fact that we're all living a bit longer, but also that we're keeping people alive a bit better. We are a bit better at relieving motor handicap now. And that's taking us into a new phase of the illness, a later phase of the illness, which is now becoming a major challenge, I think.
So I'm just going to change tack slightly now, Andrew, because obviously everybody knows, obviously you're involved with the Movement Disorder Society from the very outset, and you did many different roles within the society, culminating in your time as president. if you look back at those years that you were president, what did you, if you think, gave you the greatest satisfaction? And then I'm just going to add an extra question in there. What would you find was your greatest frustration? So your greatest satisfaction, greatest frustration in your years as the president of the society?
Well, I enjoyed, of course, I was the editor of the journal before I became the president, and that was a very rewarding period, although a challenging period for me, because peer review, which is what we all do, it doesn't help you to become an editor. It's a very different, being an editor is a very different skill, and Tony Lang, who was a great partner to have and helped me enormously during our co-editorship, and I really found it at times really quite tricky to deal with certain issues that came up, such as the issues of plagiarism, problems of drug companies not being very happy with what we were planning to publish. Yes. So there were a number of quite difficult issues to deal with, and this, of course, was just to put the time into perspective. I was the editor, I think, about 10 years ago now. And at that time, we received all the manuscripts by post. I was
just going to ask you, yes.
We wrote personalised letters to all the authors.
Yes.
And when you look at the way publishing's changed now and journals, it was really a very different world. So my office would be filled with great packs of papers and things that arrived. And of course, the next editors, Gunter Deutschel and Chris Getz, were the first to take it into the electronic era of publishing. So the editing the journal was a great privilege and something I really enjoyed doing. As president, I think my main achievement was to get the Asian and Oceanic section launched. This was something which had been mooted just before I took the chair, and I spent most of my time working with the leading players in our society in that region of the world to get that going, and that already is proving to be an enormous success.
Absolutely.
There were not many downsides, I think, because, as you know, David, very well, one of the nice things about being in movement disorders is that basically we're all different people and we all have our own interests and agendas, but we all somehow manage to get on reasonably well together, and it's a much friendlier international environment than I think some of the other subspeciality areas of neurology. So I've really enjoyed everything I've done for the Movement Disorders Society. I still love coming to the meetings, and I don't regret really any of that time. Really, I think
that's very.
And I'm very thankful for Stan and David for inviting me to go into that hotel room in Hamburg.
Yeah, excellent. That's a great.
Probably
story.
saved me from the Reaper bomb. But
keep you out of trouble. So, I mean, getting sort of to the final phase of the interview, I guess, just a few slightly more sort of philosophical things. I mean, if you look back 20 years ago, whatever, would you have done anything any differently, or do you feel that things have worked out just about as good as they could have done?
Yeah, no, I've been really very fortunate with my career after a few early hiccups, which we've talked a little bit about, but since I got on the track, I've been very lucky and doors have opened at the right time. I think that my worry is that the case history in neurology is a narrative-based medicine is in danger of falling away with the move towards science and academic medicine and the difficulties of getting grants and having the time to do this. I mean, I think I still believe that careful study of a single case, even in the field of movement disorders, can be extremely productive. As you know, I wrote a biography of Ray Kennedy, the Liverpool and Arsenal and England soccer player who tragically developed Parkinson's disease at the age of 34, and it was really going into great depth in his case that allowed me to start to think about the issues that this Congress is going to be discussing more and more, and that is the pre-motor phase of the illness. And can we actually, does the illness actually begin, or is it there many years before actually it manifests itself with motor symptoms? And that kind of work and that careful studying of an individual patient and their story, I think, is still as important today as it was when our speciality was founded in the 19th century.
Yeah, well,
so I hope that's a concern, that I hope that will not get lost or degraded to something that's inferior and phenomenological and not important.
I mean, on a similar note, I've heard some people kind of bemoan the fact almost what you were saying before about how well-versed neurologists were in their anatomy and their neuroanatomy and their ability to localize things. And now increasingly we sometimes see at these clinical meetings that people will just default and say, oh, we could get an MRI scan or we get a DAT scan done, and actually,
exactly,
you know, take a shortcut almost. Which side do you fit there? I mean, sit there. I mean, did you still feel really people should know their neuroanatomy, or do you think that in a way these modern tests have rather supplanted that?
No, I think that the modern tests have given us a wonderful opportunity for correlating what we do in the clinic with better imaging, you know, so that we can actually look at an MRI and say, did we get it right, in the same way as we did with pathology in the past. So I see them as complementary, but and of course many of the things, clinical bedside neurology is an evolving thing. We don't do what our teachers did completely the same, and some of the things that we did are no longer necessary now. So the examination, the history taking will change based on diagnostic advances outside the bedside. So, but I see this as an exciting and a dynamic area. And
so, Andrew, if you were sat on the other side of Gilead's desk, and you've got some fellow coming into you now and saying, Professor Lees, I would really like to pursue a career in neurology, and I really quite like movement disorders, what advice would you give them?
I'd give them the advice that they should choose their research. I would advise them to become an expert on something in their chosen area of speciality, and I would advise them to choose something that they, of course, we never know what's going to, it's impossible to look and see what's going to be in 20 years' time. I mean, that's a difficult thing, but I would try and encourage them to choose a research topic that would be of clinical applicability to them in their future career, rather than something that might be potentially Nobel Prize winning but very hardcore and hardwired science. So I would try and encourage them to pick up skills and techniques that they could probably use throughout the rest of their career, because not everybody who does research is going to go on doing research through. So and I would also encourage them to spend as much time as they could seeing patients, and
good advice.
Taking, you know, and seeing patients and learning the skills of being a good movement disorder specialist.
Very good. Now, you've already referred to your interest in natural history and the things that you did each summer when you were at school, and your passion for Liverpool Football Club. I think people know there are many different sides to you, other than just being a first-rate clinician and researcher. But in terms of your work-life balance at the moment, what do you do to sort of unwind? What do you do to basically outside of medicine?
Well, I write, really. I've just written a book called The Hurricane Port, which is a social history of Liverpool, which will be published this year by a Scottish mainstream press. So I like writing, and I like one of the things that I find restricting in medical science is the language that we use, and we're not able, of course, to emotionally express things. So I find creative writing very stimulating, and I try to do that. I still go and watch Liverpool games. There's not as many as I used to, and I've gone back more and more in the last few years to my old love of natural history. So I've started to study ants again a bit, and also get back into bird watching. So those are some of the things that I do.
So when you've got some extra free time in the years to come, you're not going to be short of things to be doing by the
not at
sounds
all,
of it.
no.
That sounds pretty impressive. So finally, the final question is, if you were going to be sent off to a desert island and you're allowed to take with you one CD, one book, but not the Hurricane Port, one book and one luxury item, what would be the things that you would take?
Right, well, the music would be with the Beatles, second album.
Okay.
Definitely. The book, I'd like to take, go back to Dr. Goody's advice and take Proust with me, à la recherche du temps perdu. To my sins, I have to say I've never got past the 4th volume, although I've been trying to read it on and off throughout my career. And one of the reasons I would take that is it's an attempt to make time stop still. And if it teaches you how to make time stop still reading that book, and that's what Proust was actually trying to do when he wrote it. So I hope that that would help me to pass the time while I'm waiting to be rescued.
Excellent.
And then, of course, the item, I mean, well, everybody's going to take, if you let me take a laptop, I'll take a laptop, of course. That would be to keep in touch with the world outside, yeah, an
Yes.
AirMac.
An AirMac. Excellent. Andrew, thank you very much indeed. That's brilliant.
Thanks very
a lot.
much.
Thank
Thanks.
you.